Thank you for joining me this afternoon as we go over an in-depth review of a specific case study. This is patient Brenda Jones. She's a 46-year-old female who is Caucasian. She has a past alcohol abuse, and her family and living situation is not the best. She is estranged from her family and has been in and out of homeless shelters, and she is unable to hold employment full-time. Brenda has anemia, and for this condition, she is taking folic acid supplements, 1 milligram daily by mouth. Some special considerations when taking this medication are to closely monitor the patient for relapse because the dosage may need to be adjusted. Contraindications of this medication: it can increase the risk of seizures in patients taking anticonvulsants, and some oral side effects are dysphagia or altered taste. For Brenda's condition of anorexia, she is taking megestrol acetate, 625 milligrams per day, which is 1 teaspoon by mouth. Some special considerations to consider with this medication is to be sure not to mix with dofetilide as serious arrhythmias can occur. Contraindications of this medication are pregnancy. So if you plan to be pregnant or are currently pregnant, you cannot take this medication. Some of its oral side effects are xerostomia and a fruity breath odor. During Brenda's appointment, we went over her probing depths. This image here shows all of the probing depths that were taken during that appointment. She shows generalized bleeding in greater than 30% of her entire dentition. In the posterior, she has generalized regions of 4 to 5 millimeter pocket depths with localized areas of 6 millimeter pockets. In the anterior, she shows generalized readings of 2 to 3 millimeters. Brenda also shows areas of recession in the posterior regions of her mouth. Tooth number 30 also has a class 1 furcation. On this slide, we will examine Brenda's AAP periodontal classification. Brenda has non-plaque-induced gingivitis from a systemic disease, medication, and her nutrition. She has chronic periodontitis generalized throughout her dentition, with a severity of 3 to 4 millimeters of clinical attachment loss. She presents with a systemic disease as a hematological disorder. She also has an abscess of the periodontium, which is pericoronal. There also is a missing tooth, which is number 3. Brenda presents with non-plaque-induced gingivitis due to malnutrition, combined with chronic generalized moderate periodontitis with association to blood and hematological disorder. Pericoronal abscess exists on number 32 and periodontitis related to missing number 3. On this slide, we will look at the ADA periodontal case type. Brenda presents as a generalized class 2 with localized areas of class 3. In a class 2, she has probing depths of 3 to 4 millimeters. She shows signs of bleeding, recession, and class 1 furcation. She has alveolar bone that is 2 to 3 millimeters below the CEJ, showing signs of horizontal bone loss, 1 to 2 millimeters of clinical attachment loss. She has slight loss of interdental septum and up to 15% of radiographic bone loss. In very localized areas of her mouth to the posterior, she shows the signs for class 3 moderate periodontitis. These signs include 5 to 6 millimeter probing depths, bleeding, recession, her furcation of class 1, and possible mobility. The alveolar bone is 3 to 4 millimeters below the CEJ. There's signs of horizontal and vertical bone loss. The furcation can be visible, and the crown-root ratio is 1:1. Brenda presents with generalized bleeding with areas of slight recession and beginning signs of class 1 furcation on tooth number 30. Generalized probing depths of 3 to 4 millimeters with localized areas of 5 to 6 millimeters in the posterior. Radiographic findings support evidence of mild crestal bone changes and alveolar bone 3 to 4 millimeter below the CEJ. This correlates with the oral exam and periodontal diagnosis of a case type 2, generalized, and localized case type 3. On this slide, we're looking at the gingival descriptions of Brenda's mouth. The gingival color appears generalized, moderate blanched white, with distribution from the papilla diffused to the free gingiva. The gingival contour presents as generalized, moderate rolled and rounded margins with slight areas of recession. The papilla appear moderately bulbous. Gingival consistency presents with slight, generalized, soft spongy in the free gingiva and papilla. The gingival surface texture appears moderately shiny, generalized throughout the dentition, diffused from the attached gingiva to free gingiva to the papilla. On this slide, we will look at all three of the classifications for Brenda's case type. The AAP classification presents with non-plaque-induced gingivitis due to malnutrition, combined with chronic generalized moderate periodontitis with association to blood and hematological disorder. Pericoronal abscess exists on number 32, and periodontitis related to missing tooth on number 3. The ADA case type. Patient presents with generalized bleeding with areas of slight recession and beginning signs of class 1 furcation on tooth number 30. Generalized probing depths of 3 to 4 millimeters with localized areas of 5 to 6 millimeters in the posterior. Radiographic findings support evidence of mild crestal bone changes and alveolar bone 3 to 4 millimeters below the CEJ. This correlates with the oral exam and periodontal diagnosis of case type 2, generalized and localized case type 3. For the gingival descriptive statement, the gingival color appears generalized, moderate blanched white with distribution from the papilla diffused to the free gingiva. Gingival contour presents as generalized, moderate, rolled, and rounded margins with slight areas of recession. The papilla appear moderately bulbous. Gingival consistency presents with slight generalized soft spongy tissue in the free gingiva and papilla. Gingival surface texture appears moderately shiny, generalized throughout the dentition, diffused from the attached gingiva to free gingiva to the papilla. On this slide, we will look at a bite wing radiographic image of Brenda's mouth. We can see a small spicule of calculus that is located on the distal of tooth number 2. We see the area where tooth number 3 is missing. If we look mesial to tooth number 4, we can see that there is erosion of the alveolar crest. Going down to tooth number 28, we can see that the alveolar bone is 2 to 3 millimeters below the CEJ. Distal to that, we see levels of horizontal bone loss. Mesial to tooth number 30, there is an area of vertical bone loss. And on the mesial of tooth number 31, we see that there is 4 to 5 millimeters of alveolar bone loss below the CEJ. In this first gingival image from Brenda, we can see that she presents with very bulbous papilla in the anterior region. We can see the attrition from her bruxing. She has rolled margins with areas of gingival abrasion, and the color of the gingiva presents as blanched white. On this second image from Brenda's mouth, we can see a close-up of the tissue. Again, it is showing a white blanched color. It has a shiny surface texture with a soft consistency. We can see that receding margin as well as the rolled margin. On this gingival image, we can see the probe going down, showing a 4 mm pocket depth, and we do have bleeding upon probing. We can also see the receding margin and where she has wear facets from bruxing. There's rolled margins present in this gingival picture as well, and again we can see that blanched white gingiva. On the last gingival image of Brenda's mouth, we can see that defined blanched white gingiva, areas of the receding margin line. You can see a small area of calculus, bulbous papilla, a rolled margin, soft tissue consistency, and she also is showing a fractured tooth. Now we will look at the dental hygiene diagnosis of a generalized case type 2 with localized areas of case type 3. Brenda's overall prognosis is good. We can assess this due to adequate bone support remaining and the control of her etiological factors. Her compliance with home care will better determine her final outcome with treatment. Our short-term goal for Brenda is to arrest inflammation. We will fabricate a night guard to arrest further attrition from anxiety and to use as a home fluoride tray. Our long-term therapeutic goal is for proper home care to be set in place, nutritional improvement, restorations from attrition, and frequent dental visits about every 4 months. The modifiable risk factors that present in Brenda's case are nutritional counseling, home care compliance, management of her condition, and xerostomia. Non-modifiable risk factors are her disease, which is anemia, the medications to treat both her condition and the disease, which are the folic acid supplement and megestrol acetate. When we're treatment planning for Brenda, the first thing we would do is have a comprehensive initial evaluation. We would also see her back for her periodontal evaluation. We would start with her debridement and also gingival irrigation. We would bring her back for a prophy with fluoride, give her proper oral hygiene instructions, and use sealants as preventatives for further decay. Here we can see the treatment plan and how we'll flow through each appointment. When Brenda initially came in, we did a comprehensive exam. From that exam, we did an initial debridement and gingival irrigation. Then we brought her back and did a comprehensive periodontal evaluation to determine her probing depths. From there, we were able to do a prophy with topical fluoride in office, give great oral hygiene instruction, and add sealants per tooth that needed them. During Brenda's appointment, we used Gracie instruments, including the standard, After 5, and Mini 5, with shank rigidity of standard and rigid. These were used to remove light to moderate calculus, to do fine scaling, and to do finishing strokes. We used a Nevi 1 scaler that had standard shank rigidity to remove moderate to heavy calculus. During the debridement, we used our ultrasonic inserts, both the standard and slimline, to remove heavy supragingival calculus. The following are the home care recommendations that were given to Brenda in order to help maintain her condition at home. Recommendation of ClinPro 5000, which is 5,000 parts per million fluoridated toothpaste, and also 1.1% neutral sodium fluoride gel. Over-the-counter dental aids include floss or a floss pick and Biotine. For toothbrushing, we recommend the Bass technique with an extra soft bristle brush. Brenda should hold her brush at a 45-degree angle toward the gingiva using small sweeping strokes to gently massage and remove biofilm. She'll use her ClinPro 5000 toothpaste to brush at least 2 times a day for a duration of 2 minutes. For wax, I recommended either a waxed floss or a floss pick, making sure she gently slides the floss between her contacts of the teeth, being sure to go under the tissue to create a C shape around each tooth. I also recommended a gum stimulator that she can use to gently massage the tissue to increase circulation and aid with inflammation. For mouth rinses, I recommended a Listerine Zero that she can use 2 times a day after brushing. Swish for about 30 seconds to improve freshness. Make sure not to dilute this product as it will become ineffective. And make sure that we're not using any products that contain alcohol, as this can worsen the effects of xerostomia. For fluoride, I would recommend a 1.1% neutral fluoride gel that she can place inside of the night guard tray. She will use a thin ribbon of gel inside the tray and then seat the gel against the teeth. Gently use the finger to press on the tray to distribute the gel on the entire tooth surface. Let the tray sit for about 5 to 10 minutes, and once removed, do not eat, drink, or rinse for about 30 minutes. Lastly, we will go over our nutritional analysis for Brenda. Again, her disease is iron deficiency anemia, and it is caused by a shortage of iron in the body. Without adequate iron, your body cannot produce enough hemoglobin for red blood cells. Her condition is anorexia, which is an eating disorder characterized by an abnormally low body weight, intense fear of gaining weight, and a distorted perception of body weight. Things to add in her diet include dark leafy green vegetables, red meats, and beans. This will help supplement iron into her diet. Calcium-containing foods such as yogurt, milk, and cheese should be omitted from the diet when consuming iron-rich foods because they can actually interfere with the absorption of iron. Foods containing tannins should be avoided because they interfere with non-heme iron sources from plants. These tannin food groups are coffee, grapes, wine, and corn. Some additional supplements she can add in are folic acid, 1 milligram per day, and also B12 supplements, 500 mcg per day. I hope you've learned a little bit about Brenda and how you can properly treat a case type 2 generalized with localized areas of case type 3. Thank you.